Can everyone see my screen? Great. So good morning, everyone, and welcome to our first session of the Child Behavioral Health Fund for the GMA Funder Community for 2022. For those of you who might not know me, I am Danielle Belanger, and I'm a Senior Program Officer here at GMA Foundations. Before turning the floor over to today's speaker, I just wanted to do a little level setting, lay the groundwork for the sessions to come, and set the stage for things. So we're, just wanted to give a warm welcome to everyone who is joining us here today. And we're also glad that you are able to be with us and that you've chosen to participate. We hope this group will equip you both with knowledge about the current child behavioral health crisis in Massachusetts, as well as some information on how you all in your foundations can help to address that crisis that's happening right now. So just so you all know, as you just heard, we are recording today's session. And this is really just for those who are not able to join us for today in real time. So you'll see around the Zoom room, I'm joined by a lot of my GMA colleagues, but we also have a great group assembled of participating funders that you'll see on this list here on this slide. There will be time at the end of today's session after we hear from our speaker for brief introductions among the group, so you can all get to know each other a little bit better. Today's session will be the first of our 4 90-minute learning sessions. You'll see here this tentative calendar that we have in front of you. The first hour of each will be to hear from experts, and then the subsequent time will be to get to know each other and do a little bit of funder debrief as we get into a deeper dive of the different topics. As of today, we have a grant payout that will be at least $145,000. We do have one tentative pending decision that will be finalized in early July, and then we will have an updated finalized budget to share with all of you. At that final session in October, you will see that we will be making time for you all to have discussion and grant making decisions, and then hopefully some celebration of those decisions. And we will be sharing a list of grantees with all of you at that time in advance of that meeting, but would also welcome you all to share any suggestions that you have along the way for us to include in that list. And then lastly, I just want to recognize the purpose of us all gathering here today is to learn from experts about this important topic and to hear from each other. I just want to encourage each of you to actively listen and truly hear what others have to share. Take a moment to allow everyone to have a chance to speak if they want to, and please feel free to speak from your own experiences and be sensitive to others' experiences that they are bringing to the table. You are welcome to drop questions into the chat along the way, which we will be monitoring and will gather for the Q&A after the presentation. On that note, I would like to turn things over to Dr. Donna Mosh, who will be giving today's presentation.
Thank you very much. Oh, you've got it up. Thank you.
I do.
And am I able to move the cursor? No. Okay. There we go. So thank you so much for joining me today. I'm Donna Mosh. I'm the president and CEO of the Massachusetts Association for Mental Health. I appreciate the invitation to speak with you on a topic that is near and dear to my heart, but I know is important to you. As I understand, you are really trying to tee up a number of different issues for review and consideration for future investments. And so I was asked to provide an overview of how the pandemic turned what was an urgent issue of child behavioral health into a significant crisis, and to talk about the impact of the pandemic on the behavioral health of children and youth, and particularly as it additionally affected kids from low-income communities and communities of color. So I have some data to present to you that really defines the scope of the problem pre-pandemic and then since the pandemic, and then talking about some of the challenges in in solutions, that there are solutions, but there are challenges to implementing those solutions. I'm happy to spend time talking with you after you see the slides. I really just wanted you to have a record of some facts and figures and some issues. And I've got a few images of system reform efforts, really kind of one page, one image takeaways from those, but I'm happy to get you much more information in depth. I can provide all of that to Danielle and she can forward it to you. So if we could move to the next slide. I can't seem to, oh, there. Thank
And
you.
Donna, can I just interject? We were seeing your video, but we aren't anymore. I don't know if you
Oh,
realized that, but I just wanted to mention it. There we
I think
go.
I must have accidentally hit the screen when I was trying to see if I could advance a slide.
No worries.
I apologize. Okay. So the takeaway message is that these are prevalent conditions and they're also treatable conditions. And, you know, the great irony of the pandemic is that it has affected all of our mental health and well-being. And people who were loath to talk about it before, people who thought maybe it was a failure of will to have one of these conditions, or that people could simply snap out of it, all of those old sayings, which sadly are still true, have seen that it actually, you know, one can have one's mental health and well-being affected by external environmental conditions that have nothing to do with social and economic status, although certainly COVID's had worse effects on people from low-income communities and with unstable employment and housing and other situations, but that it's affected all of us, and that it's something that we can talk about, and if we can get together and work on it, we can do something about it. And there's an interest in addressing it at a level that I haven't seen before in the many years that I've worked on these issues. And we have known for a long time that treatment worked, but that treatment rates are very low, and that the consequence of failing to treat these conditions timely is unnecessary disability, failures to develop, you know, deviations from life course that can land people in adulthood in very difficult circumstances, with some of the worst outcomes that our culture has to offer in terms of unemployment, homelessness, incarceration, and illness, not just illness with a behavioral health condition, but often with multiple chronic health conditions. So we're really concerned that as a consequence of this pandemic, there is what the Surgeon General has identified as a mental health epidemic, and that for kids, we know that integrating health and social supports works, but mounting the effort to do that is challenging. And since kids spend most of their time at school, and since schools are so challenged right now to even meet fundamental educational requirements, while we know it's a natural site for intervention, we know there are some barriers to integrating education and social services and behavioral health services and education, challenges to implementing things there. However, we also know that if we do not address this and address the mental health epidemic in the context of the schools, that we're going to have much more disruption to learning, to child development, and much greater incidence of the negative outcomes that I talked about earlier in terms of kids not finishing education and facing all the challenges in life that come along with that. And for every impact that this has had on us and people we know, the impacts have been greater on those who have lived at the margins, who were already suffering from disparities in access to care, who already had fewer resources than the rest of us. And so coping with a challenge like the pandemic, and one that disrupted employment and therefore income and resources and all that goes along with that, including housing stability and food stability and school being disrupted, all of that has been much more difficult for low-income kids and families to deal with. And we had access to care problems certainly before the pandemic, which have increased despite pivoting to virtual treatments, which for a while increased capacity. We've not been able to keep up with the pace of demand, and meeting that demand through virtual treatment, for example, is a harder calculation for a family that doesn't have tablets and screens and doesn't have resources and cannot really get access to people, particularly practitioners who are culturally responsive. So I want to move on to the next slide and give you some of the numbers just to point this out. So here are some figures about the level of need pre-pandemic, and also the point I was making earlier that so much of the need is unmet. And these are some CDC figures. And these numbers are often quoted, that 20% of kids have a diagnosable condition, but only 20% receive treatment from a specialist. And half of all the kids who have a diagnosable condition receive no services at all. This was going into the pandemic. You have a lot of children, 3 million adolescents, this figure just from 2017 and 2018, with major depressive episodes. So this is affecting every community, every school in the country pre-pandemic. And suicide was the second leading cause of death for children and youth aged 18 to 24. As I'm going to talk about later, this is really critical because half of all lifetime mental illness has its onset by age 14, and 75% has its onset by age 24. So you're in a high risk window here for the first onset of illness. You have low rates of treatment, and a lot can go wrong in that equation. And then the needs zoomed up in the pandemic. And this APA report, which actually comes from a study from one of the top children's hospitals in the Midwest, is that, a high majority of parents reporting, a toll on their kids' mental health and well-being. Schools reporting unprecedented levels of anxiety, depression, other difficulties, traumatic stress associated with this pandemic. And suicide rates increased. And there were some states where suicide rates went down, but a handful of states where they went up. And sadly, Massachusetts is one of the states. And adolescents were a larger share of all suicides in 2020 than had previously been the case. You see these figures from CDC, and CDC tracks the use of emergency rooms, showing increased visits for kids in two different age groups. The younger kids with a 24% increase, the older kids with a 31% increase. Here in Massachusetts, we saw in the last year a 50% increase in the percentage of the number of young women, meaning adolescents into very young adulthood, like 22, 23-year-olds, showing up in emergency rooms, having either attempted suicide or expressing suicidal ideation. I mean, that is a staggering increase. and a reflection of the crisis. And many of those kids are from communities of color, from low-income communities. And the problem that many of you may have heard about, referred to as emergency department boarding or ED boarding, where a person goes to an emergency room to be screened in a life-threatening crisis for admission to a hospital or some alternative. For those people who actually have to be admitted to a hospital, their stays are often long in emergency rooms, waiting for a bed to open up in a hospital. They've gotten longer. They were pretty available in the middle of COVID because nobody wanted to go to an emergency room and nobody wanted to be hospitalized. But you can only hold on for so long when you're having one of these conditions. And finally, people started flooding back into the emergency rooms. And the people who wait longest are children and adolescents. And among children and adolescents, those who wait longest are children and adolescents with complex conditions that might involve having a mental health condition and autism, for example, or a developmental disability. And also kids of color are disproportionately represented, because they are disproportionately kids who are publicly insured. So whatever disparities existed prior to COVID were increased substantially, just as the demand for care increased substantially as a result of the mental health epidemic coming out of this pandemic. So you'll have a record of this, so you'll be able to take these things away with you. I didn't put these statistics in here, but prior to the pandemic, the Blue Cross Blue Shield Foundation and the Association for Behavioral Health Care, which is the trade organization of all the community behavioral health providers, had issued studies about the wait times for access to outpatient care, which tended to be several months and might be longer if you were a child or adolescent looking for care because of the shortage of providers in that area. More recently in the pandemic, the waits that they document are 4 to 5 months and sometimes longer for kids and adolescents. So because there are delays in being seen on an outpatient basis, people wait and their conditions often continue to deteriorate until it gets to a point where the only option they have is to go to an emergency room, because at least there you will be seen immediately. For many of us, for health conditions, and for those of us who wanted to stay away from hospitals where there might be a lot of COVID cases, we made good use during the pandemic of urgent care centers. It is the rare urgent care center in the Commonwealth of Massachusetts, or anywhere, frankly, that provides urgent care for a behavioral health situation. They will deal with lacerations and broken limbs, but if you go there with an anxiety attack, you are out of luck. If you go there depressed, you are out of luck. So we have some significant gaps in the array of services that exist in the behavioral health world to intervene early and timely with emerging conditions and avoid people going into a deeper crisis. And then we have all these challenges that kids have been having, the schools reopening, as educators predicted significant challenges and they found them. And it was a very rough return to school in terms of trying to meet needs, even though many schools that could afford it got more resources into the schools to try to address some of the challenges kids were having. So here is where the quote I gave you earlier about the increase in emergency room visits, it's cited in this slide, because all of that pent-up demand and all of that lack of timely response really resulted in many more kids getting into life-threatening crises. And the kids and their families, they need interventions where they are. Kids are spending their time in schools. I will say pediatricians around the Commonwealth and across the country have worked really hard to try to provide a response in primary care settings to kids. And most pediatricians themselves feel their practices are in a crisis because more than half their practice time is spent on behavioral issues, and they aren't all equipped. They don't all have embedded clinicians, but many of them are trying to increase their ability to deliver integrated care. And we are finally in Massachusetts putting in place something called Pediatric Behavioral Health Urgent Care. I know one of your members, the Miller Fund, are people here today? I couldn't see everybody who was on the screen, but the Miller Innovation Fund was one of the funders of a study we did a few years ago, looking at the problem of emergency department boarding. The Tower Foundation was also involved. I believe they're here. Amy, I see Amy. Hi. And we have been very successful in identifying, with the support from the foundations, identifying the problem, building consensus, both based on both visits to other jurisdictions where they were doing this work and evidence from the peer-reviewed literature, and finally consensus among professionals in Massachusetts that developing pediatric behavioral health urgent care would be an important thing to do. The very good news is we were able to pass legislation and work with the administration on executive action to begin to regulate this, to set a rate. And as of July 1st, which is a couple of days away, organizations that are either selected as community behavioral health centers or go through an attestation process with Mass Health and are willing to provide same day service to existing clients and next day care to new clients can get a preferential rate to provide behavioral health urgent care for both children and adults. The Blue Cross Blue Shield Foundation, paralleling the work of your foundations on pediatric urgent care, funded a demonstration of adult urgent care. And we were able to put all this information in front of Mass Health and the Secretary of Health and Human Services and the governor's office, and they acted, and the legislature did the same. So over time, we will build that capacity in Massachusetts, and it'll be a significant improvement. And it is a testament to the power of the kind of innovation that all of you can seed with your investments, if taken and managed properly and taken through the cycle of policymaking and funding and regulatory change, can in fact become a response to a vital problem with an important new service. So if we could go to the next slide. So I mentioned this earlier, but it bears mentioning again that half of all lifetime cases begin by age 14 and 75% by age 24. And many parents, in retrospect, can say that they saw problems and were actually asking for help with things that they didn't quite know what it meant as early as age 5. So again, because we don't have enough investment in prevention and early intervention and early identification and treatment, we're putting our kids at risk, we put our communities at risk, and we really foreclose a lot of opportunity in the long term for kids to recover and do well. So it's very important that we do respond early. Because Massachusetts implemented in its Mass Health population a number of years ago a requirement that at well child visits in primary care, there be screening for social and emotional issues. We have a very high rate of screening in our pediatric population. What we don't have matching that is a high rate of response to identified problems because of the limitations in the workforce, because we lack as much integration in pediatric primary care settings as would be helpful. or because they refer people for outpatient treatment and they end up on that same like 5 or 6 month course of waiting for a visit, that then in a more urgent and fragile case can lead to deterioration and to emergency rooms and hospitalization. So we have a lot of elements in place that if we really built them up, everything from the screening to the intervention, urgent care, and enhancing treatment options, we could be doing a much better job with all of this. There are a number of policy issues on the next slide and implementation considerations. I'm really just giving this to you for the record. It's more applicable down the road when you start thinking about making investments, but that things that you need to contend with in the environment, there are still issues with parity and insurance benefits. It's not that the law is not clear that anyone who is insured for healthcare, and if that insurance includes coverage for behavioral health care, those benefits are to be provided at parity with other health conditions. However, they are not in every case. There are still barriers mounted by insurers, and because of our failure to more strictly regulate and really monitor adherence to policy, to the law, rather, to parity law, insurers continue to see what they cannot do. And that's a problem. It can be solved by tighter assessment of adherence to the law, and sadly, probably by some litigation. There have been various cases brought over the years, and there will probably be more before people are in full compliance, but we have a ways to go on that. And then the structural inequities that we talked about a little bit earlier that tend to increase the disparities that certain groups and individuals have. I'm sure there isn't one of you who hasn't heard about the workforce challenges in all of healthcare, but also in behavioral health. These are serious. Steps are being taken. Some of you have made investments in training for culturally responsive workforce, for example, and expanding opportunities for the development of training and education pipelines for various kinds of financial relief, including loan repayments and scholarships. Our legislature has stepped up, the administration has stepped up, and we are now doing, with the support of several foundations in Massachusetts at MAMH, we're doing an inventory of all these opportunities that I think will be helpful both to people interested in coming into the field and knowing what's available, but helpful to the rest of us in figuring out where the gaps might be and what we will need to do next. And that should be available in July. The Metro West Foundation, the Blue Cross Blue Shield Foundation, and the CF Adams Trust are supporting that inventory. So I mentioned before early identification and prevention and crisis response, care integration. All of these things are important to address as we go forward. Accountability standards and innovation. I just want to say it again. Urgent care is a great example of an innovation we would not have had without the original investment in exploring the idea and building consensus and testing the idea. Mass General Brigham is about to fund, and we're managing the implementation of this, investments in 5 partnerships that are targeted to communities of color and organizations that serve a very diverse group of patients, to develop partnerships between clinics, community-based clinics, and their local schools, where the schools would effectively become a preferred customer of the clinic for its pediatric behavioral health urgent care services. To see if this, having this preferred relationship would help the schools in managing the crises that kids are finding themselves in, and to avoid using the school resource officers, the school police officers, to intervene or to put kids in an ambulance and send them to an emergency room. Instead, they would have on-site staff from the clinic who could intervene and help to work with the child, work with the family, work with the school. We have high hopes for this demonstration, and we'll be launching the RFP actually next week. So again, another example. So on the next slide, again, an example of how a foundation focusing on convening people and bringing to the table the best ideas has been instrumental in Massachusetts, and actually beyond, as I'll talk about in a moment, in forming a vision for how we can move forward to fix the gaps and address the unmet needs in the behavioral health system in Massachusetts. So Blue Cross Blue Shield convened, and I know some of you were a part of that working group. Blue Cross Blue Shield convened a number of stakeholders from all sectors a couple of years back to work through, what are the issues in the system? What are viable solutions to these issues? How would we tie all of this together in a system of care that would really produce better results for people? And this is the kind of snapshot, if you will, of the continuum of behavioral health services, starting, as I talked about earlier, in the physical health arena, where we're all seen more routinely than we might be in a specialty sector, with screening and early intervention, and moving on to more readily available than we have now, community-based treatment and recovery support services. When emergency services are needed, really trying to start with urgent care interventions and crisis stabilization, but ultimately, if acute treatment is needed, moving on to that. But seeing what use can be made of intermediate settings that are less restrictive and less expensive, and keep people better integrated with their families and schools, and if your kids are in the community, is to have some non-acute 24-hour supportive services available, so that people could either be diverted there rather than a hospital, or step down from hospital back into the community. So this became a major part of the consideration of the Executive Office of Health and Human Services in looking at how to reform ambulatory behavioral health services. It also, as the next slide will demonstrate, is something that I am part of, something called the CEO Alliance, which started as a group of 14 executives of national and regional public policy, legislative advocacy, and membership organizations around the country. For example, the American Psychiatric Association, the American Psychological Association, Mental Health America, the old National Mental Health Association, NAMI at a national level, and regionally, MAMH and the PEGS Foundation in Ohio, the Wellbeing Trust in California, and the Meadows Mental Health Policy Institute in Texas. And we got together to formulate a vision for integrating and unifying systems of care across the United States. I actually provided everybody with the Blue Cross Blue Shield framework. And, just to say, here's what, one state's been working with, and others contributed similarly the things they've been working on. But it's pretty interesting how we aligned with a number of, in terms of a service continuum, a number of the elements, and the importance of starting with early identification and prevention, and having a robust emergency and crisis response, having as fundamental to everything we were doing the commitment to equity and integration, and addressing parity, addressing standards, and addressing workforce. So the next slide is actually what Massachusetts came up with in what's called the Behavioral Health Roadmap. So based on the input from all of those who worked at the foundation to map out that continuum, as well as input from across the Commonwealth, the Secretary of Health and Human Services, Mary Lou Sutters, met in town meeting forums, listening sessions across the state. And she and her staff worked also with a lot of expert input beyond those meetings and formulated this construct for really enhancing the ambulatory behavioral health response in the Commonwealth. Again, trying to get upstream, having for the first time ever a centralized front door to treatment. This is actually going to go live in January, 24-hour a day, 7-day a week phone line, no wrong door, as she's saying, but one number that people can call, staffed by master's level clinicians who can either do a quick assessment and triage to more urgent care or emergency care if that's what's needed, or help people make an appointment for urgent care or outpatient care, counsel people through how to navigate a system of care. They're going to be using a tool they're going to be using several tools as their database or information base in this new front door, including Network of Care, which again, with a shout out to foundations, was an effort funded by several foundations here in the Commonwealth, Metro West, Blue Cross Blue Shield, and CF Adams, to develop a searchable database of over 5,200 behavioral health and related social services, searchable by zip code, by condition, by service type. There are many ways to search it. And a 30,000 item library to help people understand behavioral health and all health conditions. What are the best practices in treating those conditions, how to maintain one's health and well-being, et cetera. So they're capitalizing on a lot of the efforts. Urgent care will be a part of this framework, as I said before, under urgent and crisis treatment, enhanced outpatient treatment, which integrates mental health and substance use treatment for the first time, and more focus on the integration with primary care. So they're also adding beds for acute treatment, both before hospital and after hospital treatment, what I call subacute treatment, but also inpatient beds for kids and adults, to try to, enable us to have a more timely and responsive system. So I want to just finish up and then leave time to talk a bit. If we could go to the next slide, with schools as a site for intervention. Kids spend a lot of their lives in school, and much of the disruption that they experienced in COVID had to do with not being in school, where so much of their development is supported, where their socialization is supported, and clearly where learning is best done. And it's been a place that in some communities where resources have been available, kids have been able to also get social and emotional supports to help their development and to help with timely intervention when they were feeling challenged. But many schools in our Commonwealth haven't been able to afford those things. It's remarkable that with money from ARPA, the federal funds, and some additional monies from the governor and from the legislature, there's now more money on the table to make investments in schools than we have seen in decades, probably ever, as some of the educators tell me. So there is a real opportunity with all of these resources being brought to bear to make investments that are sensible in interventions and services that we know work, and to try to level the playing field. between the schools that have and the schools that have not, prior to this, been able to access resources to get the job done. Obviously, a lot of the control for that is in the hands of educators, but we have a job as advocates, and I'm sure you as potential funders can really have influence on the considerations that are on the table for how to go about and do that job. It's going to take years to, fill gaps, to level any playing field. And there's time to intervene. That's something something I'd like to leave you with. And there's plenty of time for innovation. And so I just want to encourage, as you're considering the future and where to invest, thinking about ways to help to shape the investments that are coming from the government, and sometimes targeted investments from a foundation that create a focus and a purpose and provide flexibility, can kind of drag along with it, if you will, some of those other resources. And so I encourage you to consider that. There are a couple of slides with information. There is a slide, 2 slides up with a graphic about, this one. So there are a number of things, initiatives going on in different schools. Many of these have actually been funded by some of you and others who are not here today. Some are funded by education dollars, both federal and state. But I didn't want people left with the impression that there was nothing going on. Something like the BRIGHT program, the Bridge for Resilient Use and Transition model programs, that's been funded by the Smith Foundation and by the Klarman Foundation. This is something that is in many schools. Many years ago, going back 20 years ago, when I was sitting on the board of the Metro West Community Health Foundation, we actually gave a couple of the early grants for BRIGHT to schools in the Metro West. And that has built up over the years. So I know many of you have had a hand. It's not just those 2 foundations, others, Metro West and others, have funded sites in schools in your communities. And, some of the other efforts in suicide prevention, again, there are schools that have certain programs that work very well and schools that don't have as much as they would like to have. There is a real opportunity to step back and say, we have some very useful programs, things like Active Minds that help young adults with self-advocacy. Now the Birch Center, which is developing at UMass, which is developing the capacity to consult with schools on best practices and curricula for increasing mental health education in the schools and awareness and behavioral supports. It looks like there are all these pieces, and one needs to think about how to integrate and coordinate these, but also to realize, as I said before, that some schools have many of these and some have 1 or 2. And we need to think about how to help all of the schools come up to par. So the final thing here are some facilitators and barriers to trying to do this work, to improve our response to children and youth who are facing challenges with their mental health and well-being. So we do have very high rates of insurance in the Commonwealth if we can only get the insurers to actually honor commitments and pay for things. We have very good benefits in public health, and actually in this last year, it'll just be a year on June 30th, private insurers took up a set of benefits that had been called the Rosie D services, the Children's Behavioral Health Initiative benefits, 6 new services. And those are gradually being used and adopted by different private insurers. So there's a lot of promise here, but there's a lot of work to be done in really bringing things to their full fruition. I want to apologize for my dog who's not happy that I've shut the door on him. While we have this little discussion, he's making himself known outside the door. Anyhow, so we do have these behavioral health workforce things to tackle, but we also have a relatively large behavioral health workforce compared to other states. Our problem is that the workforce we have is not all in, if you will, in serving people with insurance, which is a lot of us. And for those of us who can't put cash up front and take the risk that we might or might not collect part of what we paid the clinician from our insurer, 52% of all psychiatrists who don't take insurance are basically not available to people who don't have that option. More than 52% of clinical social workers and psychologists. So more than half of our workforce, we need to find a way to re-engage them in providing care to people with insurance who cannot lay cash on the line. And there are ways to do that. This loan forgiveness that the Senate passed, and the House and the Senate now in Massachusetts, is like a public health service grant. If we pay off your loans, you give service to people who are insured. We'll see how those compacts work out, but people are availing themselves of these things. And then implementing the roadmap and this unified vision are critical. We have, again, more resources on the table than we have in the past. We need targeted investments to really push this along in the right direction. And there are barriers, there are silos. I didn't even mention all the silos in healthcare because I know you've heard it all 100 times. But there is that obvious silo between health and education as well. And then the persistent low rates of access and continuing disparities for people from low-income communities, from communities of color. We have so much more to do. I trust that with your help and your guidance, we'll do a better job of what's ahead of us. And thank you for listening. And I'm happy to take any questions.
Thank you so much. That was so much that you've managed to fit so much in such a short presentation. So I appreciate it. As you were speaking, there were some questions that folks dropped in the chat. So I think we'll start with those, and then folks should feel free to chime in as well, speak up if you have any questions as we're going through. So the first couple of questions are from my colleague, Amy Shorey, who I think you know. And so she was asking, can you tell us a little bit more about the supply side? The psych beds and ED bottlenecks are well publicized. Do you think there is an absolute shortage of qualified clinicians, or are there creative ways to increase supply quickly?
It's a good question. Well, there are two supply issues, and they are intertwined. So we have several thousand psychiatric beds in the Commonwealth, acute, licensed acute beds for adults and kids. On any given day, 400 to 600 of those are not staffed. They are not open because we cannot staff them. And that is a huge challenge. So everybody says, oh, we need more beds, we need more beds. Well, actually, we need more staff to operate all the beds we have licensed. That said, there are some gaps in the beds, how beds are dispersed geographically in the state, and the extent to which we have sufficient supply of what I would call specialty beds or subspecialty beds, meaning beds that can best treat a child who has not only a psychiatric condition, but also has autism spectrum disorder, or may have autism spectrum disorder and an intellectual and developmental disability. There are only a handful of beds in the Commonwealth that are staffed to serve kids with those multiple conditions. And of the beds that are already licensed, there is a whole unit of those beds that is not open and has never been open since the day it was licensed because of staffing problems. Cambridge, Somerville, Cambridge, as I still call them that, Cambridge Health Alliance, they are opening some new child and adolescent beds, including a unit for kids with these complex needs. But again, we really have to work on the training and supply. I mean, the problem with the workforce, goes back to something that we've all talked about for decades and is well documented, and not by people like me who, even though I've been a state agency director, I've been a CEO of private healthcare companies, I've been a researcher, I've done a lot of different things in my years, all trying to get at this challenge of people who are at risk for or live with these conditions, needing better care. But by the top actuaries in the country, Milliman, who document every couple of years how doctors and nurses and social workers and psychologists get paid, and compare them on scales, basically against their peers. And every time the numbers come out, including the most recent numbers from Milliman, psychiatrists, for example, get paid 30% less than primary care practitioners. Now, guess who has to train a couple years longer at more expense to become a psychiatrist than you do to become primary care, but you get paid 30% less. And when you stack the psychiatrists up against their specialist peers, the gap is 50 to 60%. So they all have to pay off the same debt, right? But they aren't all, because the rates are so low, getting the salaries that the others are getting, and therefore either have to spend like the rest of their natural life paying off their debt, or they do what many do, which is try to peel off and go into private practice and not take insurance and charge rates where they feel they can pay off their debt and raise a family and do whatever else. And therefore, they're not available to a whole bunch of people. It's not that this doesn't happen in other fields of healthcare, but it doesn't happen in most. I mean, concierge medicine is, in the rest of medicine, still a pretty small thing where people are paying cash up front. I mean, plastic surgery, yes, but, we are plagued by this problem, and it's a problem of our own making because we have devalued this area and we have consistently failed to invest. We've thought it was okay to pay lower rates. We've let the insurers think it was okay to pay lower rates. And now climbing out of a hole that is a 30% problem is a big damn deal. And I will say, again, we are fortunate to live here in Massachusetts where, between the legislature and the administration, they've tried to chip away at this. But for a few years, it was like 2% a year, 1.5% a year. None of the other providers were getting any increases, and behavioral health was getting a couple of %. Well, that wasn't even keeping up with cost of living. So while the other providers were getting hurt, we were still not climbing out of the hole. So this year, they actually gave across the board 10% increases in ambulatory behavioral health. That is a huge thing. But we need 2 or 3 more years of 10% increases if we're going to just get even with others practicing under the same level of license and be able to, have higher reimbursement rates and therefore be able to pay people better. And people say, well, sorry, you're kind of late to the party. And we really have these, we have to live under caps, and the Health Policy Commission has these caps, and we just can't do this because it's a shame, but you're the last in line. Well, honestly, that is just like nonsense and not true. And, there are ways to manage within the cap. We have had demonstrated return on investment analyses that show if you invest more in primary care, you invest more in behavioral health care, you will actually save on specialty expenses and hospital expenses, and avoid people developing multiple chronic health conditions that have huge costs. So we just need we need leadership and determination and clear thinking about what is the right thing to do for human beings and for our healthcare system. Anyway, I'll get off my soapbox.
Thank you, Donna.
Yeah.
I'm going to combine a couple of questions that have come in through the chat as well. Can you talk a little bit more about in school and out of school interventions? So both, you mentioned some, I think, students are in school so much of the time that that's a good approach to getting services. But I wonder if you can also talk about some out of school opportunities or community organizations like, rec teams or that kind of thing.
Yeah, I
And
mean,
how do you, and
there are
ensuring quality control, and those I think is the other piece of that puzzle, is how do we make sure that those are actually useful programs? So that was the part of the question.
Okay, well, there are some great program examples out there. I'm not trying to single these folks out because as compared to others, but I know some of you are familiar with Doc Wayne, some of you have been involved in funding it. Having more normative supports that don't involve declaring yourself a patient to get help and are provided in more natural settings that kids actually are willing to kind of take to makes so much sense. And honestly, things like boys and girls clubs and, things that provide structured and supportive social supports in our communities can make a world of difference. Honestly, ensuring food security is a mental health intervention. Tackling racism is a mental health intervention. I mean, it doesn't have to be a therapist, at the other end of the Zoom or on a couch or whatever the analog is. I mean, so much of these core things need to be addressed. It's, people, the hierarchy of basic needs. But I think for young people developing, people talk about, that it takes a village. They talk about the significance that one caring adult makes in the life of a kid who might otherwise be challenged. I truly believe those things and have lived that experience. And we have a lot of programs that are really structured not to deliver psychotherapy, but to deliver that connection, to deliver those supports, to deliver those meaningful relationships, and to help support kids through their development and help them. I think if, there are some interventions like that help to improve mental health awareness, not just in, healthcare settings, but in normative everyday settings, whether that's schools or churches or temples or recreational centers, wherever it is. If people can understand more about mental health and well-being, understand how to protect it and preserve it, and it's a lot that's not about treatment that can do that, and how to, when a problem is emerging, either get themselves help or get somebody access to help. I think it can make a big difference. So I think those investments in health education and health promotion, in community supports, whether those are recreational or substantive around things like food and materials and housing stability, are all very important.
Thank you, Donna. And one last question to wrap things up. I'm wondering if you can comment at all on any efforts that are being made to destigmatize mental health.
Mm-hmm. Well, I will say that we're still battling stigma. MAMH was founded in 1913 to combat stigma. And here we are in 2022, heading into our 110th year. You could say we're a huge failure because we certainly haven't eradicated stigma, but stigma is a pretty thorny thing. And, it is discrimination, and discrimination is, and the bent to discrimination, which is, is the countervailing force to that arc that Martin Luther King talks about, bending toward justice. I mean, it is deeply rooted in our country and our culture. And as we've seen with so many other things, until something affects everyone more broadly, until people see it as more of a universal experience, a lot of it's not going to fall away. And COVID has spawned that with people, but I find myself wondering when the window of opportunity here is going to close, because I do think, as I see people getting more anxious about the economy, more anxious about their perceived rights to their differences, et cetera, that is all going to be counter to eradicating stigma. And it's worrisome. I think we have to tackle it when we see it and call it for what it is, which is discrimination. It's not just, a misunderstanding, or if you only had a lesson in how these conditions affect everybody and you can recover with treatment or whatever, it's all going to melt away. That isn't true. And I think those of us who are in that business know that what it takes is people living with one another and working with one another and going to school with one another, and everyone having the experience that these things are part of the human condition and that we're all in this together, and that we can work together to address it and resolve it. If we don't do a better job at that, I think we're just going to see people revert, as I'm afraid they're going to revert with these other challenges, to their stereotypical responses.
Thank you so much, Donna. And we will be, just so folks know, we will be sharing around the presentation from today. So if you want to reference it in the future, you can dig into some of those great facts that Donna included in the slide deck. And thank you so much for taking the time to join us today, Donna.
I'm happy to do that. And Danielle, I'll send you some of the full reports that I've cited here if those are helpful to you.
Great. Thank you so much, Donna. Have a great afternoon. Take
Bye.
care.